Well, kia ora koutou katoa, no mai haere mai ki te manatu hauora. Very nice of you to come up today for today's media update. Thank you again. Now, today I'm very pleased to be joined by Dr. Andrew Old here on my left. He has just started this week as the Deputy Director General in charge of the Public Health Agency, and he'll be contributing to today's stand-up, also and including the questions that you'll have. And as I step down at the end of next week from this role, you will see Andrew taking over, fronting the media conversations around COVID on behalf of the Ministry of Health. So I'm going to start today with an updated assessment of where we're at in our current outbreak, and then touch a little bit on the other viruses and illnesses circulating this winter, and of course emphasise the steps that everyone can take, including latest advice around ventilation. I'll hand over to Andrew, who's going to detail some of the changes we will be making to our mortality death reporting, and he'll walk you through those. First, an update on the daily numbers. Today there are 10,772 new community cases of COVID-19, with 788 hospitalisations and 21 deaths to report. So our 7-day rolling averages are for cases 9,858, for hospitalisations 764, and deaths 23. These have all increased over the past week, as you will know. So overall, in recent weeks, we saw rapidly increasing case rates. However, this does seem to have slowed in the last week or so. It's encouraging, but at this point we're treating that with caution. At this stage, we are still expecting further increases in cases and hospitalisations, according to the modelling that our teams have done. So effectively what we've seen in the last week is about a 4.5% increase in case rates over the previous week. Now that compares with a 33% increase the week prior. So again, that rate has slowed. And our case rates and wastewater results do show that the cases are increasing across all regions around New Zealand. Again, our hospitalisation rate for the week to 17 July increased by 28%, so that's quite a significant increase. And nearly 1 in 20 patients admitted to hospital at the moment are returning a positive COVID result. While the initial Omicron outbreak back in March and April was most prominent amongst younger population, the rates are now higher in our older folk, particularly over 65s. So for the week ending 17th July, there was also a significant increase in the number of cases in aged residential care at 793, an increase from 729 the week before. So that was a significant increase, but again it was slower, quite a bit slower than the increase the previous week. However, overall these figures reinforce the comments I made last Thursday. That is a significant increase in Omicron cases, a surge driven in particular by the more transmissible BA5 Omicron subvariant, and later this week we will be able to look at what the proportion of cases are that are due to the BA5, but we're fully expecting that will have increased and will continue to do so. This is entirely consistent with what is happening across the Tasman in Australia. I'm sure you're following that, and indeed in many Northern Hemisphere countries, including those that are experiencing heat waves at the moment, so they're not in winter. I want to just update on the BA2.75 subvariant of Omicron, and we have had confirmation of 2 community cases in Auckland with this subvariant. It's the first time we've found it in the community, but both these cases are linked to known imported cases and are isolating at home. These are in addition to the 6 BA2.75 reported cases that we've previously talked about, all of which are associated with recent overseas travel. So far, this subvariant has only been found linked to the border. We're regularly assessing the new subvariants and the emerging evidence on their transmissibility and severity. At this stage, we don't see anything that would indicate the need to change our public health settings. That's the conclusion other countries are drawing as well around BA 2.75. This subvariant does have some characteristics that enhance its ability to evade immunity, which is the same with the BA 4 and 5 subvariants. However, there's no current evidence that it leads to more severe disease, and so we'll keep assessing the evidence on that. In terms of a winter update, as well as COVID-19, as you know, we're facing the usual pressures on the health system that we see every year through winter, except of course for the preceding 2 years with our borders shut. And we have, in addition to that, a high burden with the number of staff off sick, so this is really compounding things. It's not unexpected, but it has appeared earlier in the winter season, particularly with that early peak of flu, and so that's creating quite a lot of pressure in our emergency departments, general practices and medical centres. I can assure you, as I said last week, that all parts of the system are working together on a daily basis to make sure we respond to those pressures, and the public can be confident that if they or their loved ones need urgent hospital level care, they will receive it and it will be delivered professionally. And I want to thank all our workers that are continuing to work for their professionalism and support. As you know, last week on Thursday, the government announced measures in response to the winter pressures, including greater access to masks, as well as rapid antigen tests and that widening access to antiviral medicines. However, with COVID-19 cases expected to continue to rise in the coming weeks, I would call upon everyone to once again assiduously take the simple steps that will lower the impact of COVID-19 and other respiratory illnesses this winter. Vaccination, mask wearing, staying at home if unwell, regardless of your COVID test result, uploading your test result into the on the web, and waiting until you are very well, completely well, before visiting the vulnerable or elderly. A comment then on ventilation. Studies that track the concentration of carbon dioxide that effectively measures the air that is being breathed out by people inside show that, as well as wearing a mask, good ventilation can reduce indoor transmission of COVID-19 and other respiratory viruses. Even relatively simple steps like opening windows can help considerably. Having several windows at different ends of a room open, and it doesn't need to be all day, just for a short period, really improves ventilation and reduces the risk of COVID-19 being transmitted between people in a room. So opening all windows, even for 15 minutes when a room is not in use, also helps to flush out stale air and reduce the risk of infection for those who are using the room subsequently. In a house, ventilation can also be improved by running a kitchen and or bathroom fan for a period. They're not designed to be run continuously, but they do again help to clear out stale air and bring in fresh, clean air. Even with good ventilation, and especially if you cannot control the ventilation in a room, it's important to continue to wear a well-fitting mask, and a good rule of thumb is to wear a mask anywhere you are in an indoor environment outside the home. Finally, just on meningococcal disease. As well as influenza and COVID-19, the meningococcal rates increase during winter. And this is because bacterial infection. Predominantly in teenagers and young children, it can be very severe. And at this stage, there are no known links between these cases, so it's not classified as an outbreak per se. And the increase in the case numbers is very consistent with what we see each year. However, as I said, meningococcal disease can lead to serious illness and even death, and it's a good time to remind health professionals and indeed everybody, in particular parents, to be alert for the signs and symptoms. All whānau can take steps to help protect their young ones. So, common symptoms are sudden onset of fever, headache and a stiff neck. Other symptoms include nausea, joint and muscle pain, vomiting, and increased sensitivity to light and or confusion. Children or young infants may show different signs or symptoms, and this can include inactivity, irritability and vomiting. If you notice any of these symptoms, and you will see that they are different from the symptoms of flu and or COVID-19 in many respects. The latter have got the fever, yes, but tend to have a runny nose, cough and sore throat. These are not the symptoms that are typical of meningococcal disease. If you have any concerns, contact your doctor without delay or call Healthline at any hour of the day or night. Early intervention here can be life-saving. I'm now going to hand over to Andrew before making some final remarks, and then we shall open up for questions. Kia ora.
Thank you, Ashley. Kia ora koutou katoa. As mentioned, my name is Andrew Old and I'm the new Deputy Director General for the Public Health Agency within the Ministry of Health. This is just day 2 in the job, and I'm very excited about the opportunities for the newly created agency as part of the wider health reforms. So the Public Health Agency has been charged with leading all public and population health policy, strategy, regulatory intelligence, surveillance and monitoring, and has a key role in providing advice to ministers on all public health matters. But more broadly than that, it's about protecting the public and improving the health of communities through greater emphasis on equity and the wider social and commercial determinants of health, such as income, education and housing. It's about working with other agencies to create a supportive and enabling environments that help. So that said, today I am still going to be talking about COVID, specifically how we are reporting COVID deaths. As you know, part of having an effective COVID response is about the intelligence that we provide and having a really strong understanding of the burden of COVID-19 on our communities, including when those infections lead to deaths. The Ministry has recently announced improvements in the information collected about COVID-19 hospitalisations, and so while we still report daily number of people in hospital with COVID-19, improvements in information gathering mean we can now also start reporting on people hospitalised where the main reason that they're in hospital is due to COVID-19 or with COVID-19 as a contributor. This is a more meaningful measure in terms of understanding the real impact of the burden of severe disease from COVID-19. Today I can announce we will be making a similar change to the way we report COVID-19 deaths, shifting away from reporting all people who have died within 28 days of a COVID-19 infection to people who died because of their COVID-19 infection or where it was recorded as a contributing factor. While we will continue to report additional deaths with COVID-19 in the daily updates, the focus on reporting total COVID-19 deaths will shift to cases where COVID-19 is either the underlying or a contributory cause of a death. So these are deaths that can be wholly or partly attributed as a better measure of the burden of disease on the community. Over time, that will also allow us to provide more and better demographic information about the people who have died from COVID-19 over the course of the pandemic, such as by age, ethnicity and by vaccination status. So using that updated approach, that is deaths from COVID-19, as of the 19th of July, we have reported 1,252 deaths, where COVID was either the underlying or a contributing cause of death. This figure is lower than some of the other ways we've counted deaths of people with COVID-19 to date, but still shows that in somewhere between 2/3 and 3/4 of cases, that the person who has died with a COVID-19 infection, that infection was either the cause or in some way contributed to their death. This number may of course rise over time as more COVID-19 deaths are assessed and classified. So it's important to note that this updated approach is consistent with the approaches taken in the United Kingdom, Australia and the United States, and therefore more accurately reflects the contribution of COVID-19 to death numbers and overall rates. This updated approach will now become the way that we report our figures to the World Health Organization going forward. We will start reporting these updated figures in this way on the website from Friday this week. I also just want to make a note about the fact that whether we're counting deaths from or with COVID-19, New Zealand has a lower cumulative COVID-19 mortality rate than many other countries due to our successes early on in the pandemic. In the United Kingdom, for example, the cumulative COVID-19 death rate is 2,648 deaths per million population, and in the United States it's 3,057 deaths per million population. If New Zealand had had the same total rate of deaths as the UK, we would now be reporting over 13,500 deaths from COVID-19, and if we had the same rate as the USA, it would be over 15,000 deaths, compared to the 1,252 that I mentioned just earlier. Now, as part of making improvements to reporting on deaths, the Ministry has also is now also reporting 69 additional deaths of people within 28 days of being reported as a case. These are all people who have been previously reported as being a COVID-19 case, but did not have their deaths recorded at the time. So most of these deaths have now been included as a result of changes to the reinfection guidance, which was issued last month. This allows us to now treat a positive test result between 28 and 90 days of previous infection as a true reinfection. And so there are an additional 40 people of that 69 who died within 28 days of getting reinfected with COVID-19 who are being added into the death totals from today. There are an additional 29 people with COVID-19 who were reported as cases but whose deaths were not initially uploaded as deaths into the database at the time. It's important to stress that these additional deaths reflect changes in reporting practice and don't in any way relate to the care that these people received. And all of those 69 deaths have occurred since the 23rd of March this year. So those deaths are being progressively added to the total deaths within 28 days of being reported as a case. And as more is known about each death, they will be classified as either deaths from COVID, primarily or partly, or unrelated to COVID-19. So just to be clear, as we now are much better at reporting deaths from COVID, and we can better differentiate between whether those deaths were from or COVID or whether COVID was a contributory measure, that is the key metric that we're going to be shifting our reporting to over time. Back to you, Ashley.
Thanks again, Andrew, and I dare say at Andrew's pofferty yesterday morning when I said he was joining me at the stand-up the next day, he thought I was joking initially, but anyway, you'll see that he's more than able to hold his own here. I should say just one of the other reasons why we are confident about moving to reporting deaths in this way is we now have the systems in place to code the deaths within a few days, not within 1 or 2 or 3 months, which is the usual system, and is still the delay that many other countries have. So we will be able to provide in a very timely way that categorisation of deaths. So a final comment for me. Our response to COVID-19 to date, since February 2020, has relied on everyone's willingness to take the steps needed to protect not just themselves but others, and in particular our vulnerable populations. That willingness to do this, to act for others, remains our greatest strength this winter, and I want to finish by paying a huge thanks to the many people who are already doing so every day. Happy to take questions.
Mr. Bloomfield, why did it take so long? Any particular events or activities that are driving this increase in cases?
Not specifically, and we've found right through the pandemic that a lot of transmission happens in households and places, of course, where people are in close contact.
I'm thinking about the weekend socialising, the big rugby matches and the like.
Not specifically. I mean, what we do know, and this will, I'm sure, be your experience, is that there is infection that is widespread in the community. And so rather than particular places, of course, it's thinking about how do we make sure that wherever people are going, they are safe, and hence the measures that we've outlined and reinforced.
I know there aren't any gathering limits at the moment, but what is your advice regarding gatherings, large conferences, events, things like that?
Well, I would certainly encourage those who are organising gatherings to think very carefully about what measures they can put in place to protect people, and in particular to place a very high expectation on people who are invited not to attend if they're unwell or if they're recovering and are still symptomatic. So in particular, for my part, for example, this evening I have a formal farewell, which was going to be quite a large event. We've now gone for a much smaller, modest event with no food and drink. Everyone will be wearing masks, and the a large number of people that were invited will be joining by Zoom. So I hope they'll join by Zoom to see that. So look, I think this is the time, it's this next 6 weeks as we go through winter. Everyone knows the things that will help reduce the transmission of COVID-19, and for those who are organising events, widespread use of masks is incredibly helpful. There was a question over here, I'll come back to you then.
So why has it taken so long to get that system right for coding the deaths? I mean, we're obviously 2.5 years or so into this.
Actually, that system's been in place for some months, and one of the reasons we're shifting the reporting now is that the WHO has changed its request of us in terms of our reporting, and secondly, we also just wanted to give plenty of notice about why we were doing it. I should say, and Andrew has said this, and just to reiterate, we will still continue to report the number of all deaths within 28 days on our website, but the number we will be highlighting each day will be the one that is the deaths where COVID was the cause or a contributing factor.
And when it comes to the infection prevalence survey, can you just explain exactly how that works and what the antibody testing will measure, and how many Kiwis might be contributing to that?
Well, I'll do my best on this. So there are two different prevalence surveys. The first will be a survey that is rolled out over 6 months with around 1,000 New Zealanders each week invited to participate and report on symptoms and their experience of symptoms that could be due to COVID. And so that will be a cumulative number of people over 6 months, and this is to report on what and give us an idea of what the actual prevalence of COVID-19 is in the community at different points in time, in fact on a weekly basis through that 6 months. The other survey, which is the seroprevalence one, will just test a number of people at a point in time and that's a blood test, to look at the antibody levels in their blood, and that will give us an indication of just how many people have got antibodies so immunity to COVID-19, either from the vaccine and or from infection. So two different surveys, both are well developed and nearly ready to start rolling out in the next few weeks.
And also, with schools struggling with staff illnesses at the end of last term, what's your advice as they prepare for another winter term?
Well, what we have seen is that schools that put in place the measures, the very simple measures that we've talked about here, particularly use of masks, are the ones that have managed to reduce infection amongst staff and students. And our strong advice has been, and masks have been distributed to schools to help support this, is particularly for that first 4 weeks of this next term, to consider, and strongly recommended, but to consider asking all students and staff to use masks for that first 4 weeks, and masks are being provided to support that. It's not compulsory, but it's a strong recommendation.
The Prime Minister is...
Just lastly,
sorry,
is this possibly your last presser with us?
Let's see. Yes, I don't usually find out till much closer to the time, so let's see. But anyway, Ben, and then I'll come to you, Mark.
The Prime Minister's referred to 3 key parts of the toolkit around protection: mask wearing, vaccines, isolations. Is there any discrepancy between Ministry of Health advice and the government's current settings on mask wearing? Because it seems obscene that we would tolerate this level of hospitalisations and deaths when plainly there are more mask wearing that could be happening.
There is no difference in the advice we're providing and the current settings. And in fact, I've just read some updated advice from my team this morning that confirms the current advice that we're putting up. And just remembering that even under Orange, there is a number of settings where masks are required to be worn. So the issue is not about whether masks are compulsory or not. The issue is about whether people are wearing them. And that's why last week's announcements put a big focus on wider distribution of masks so that we can be sure we're doing everything we can to support people to use them. So I can certainly say on mask wearing, the current settings are fully consistent with our advice.
So the judgment is that you just can't make people wear masks anymore. You just lead a horse to water sort of stuff.
Well, as I say, there are still a number of settings where masks are required to be worn, and I can observe over this last weekend that I saw high compliance in the settings I was in where masks are required to be worn, not 100%, but we are also aware from our surveys that people know what those settings are, and that there's a high degree of awareness, and still, in my view, a high, and I hope even higher degree of compliance with that.
And just on vaccines, vaccine uptake has slowed considerably. Is there more that can be done to encourage New Zealanders to be vaccinated?
Well, we're doing everything we can, and we have seen, of course, an uptake in vaccination with the opening up of the 4th dose. And so that's pleasing to see, but just, again, strongly encourage people, even if they've had Covid-19 recently, or if it's 3 months since, go and get either your booster or, if you're eligible, that 4th dose.
Do you have figures on this?
Sorry, Mark.
Just quick follow-up, but do you have figures on the booster uptake for the second one?
Yes, we do have figures, and we can make those available afterwards, no problem.
Have you advised ministers or the Ministry of Education that masks should be required again in schools for those first 4 weeks? And if not, why not? If there's such a compelling case that people should be using them, why not require it?
We were asked to relook at that, and we did, working closely with our Ministry of Education colleagues, and we have settled on the advice I've just explained, that actually, for where we are at the moment, and also in addition to providing the masks, which were announced a couple of weeks ago, 2 or 3 weeks ago, that have gone out to schools, strengthening our recommendation, so a very strong recommendation that schools do this, and many are, and our recommendation is that they all look at and requiring mask use for that first 4 weeks of the next term.
Last week you showed sort of modelling and said that we would need to see a sort of immediate change in behaviour to start to bend the curve in a favourable way. From what you've seen since, have we been successful at that so far?
Well, as I commented, numbers have slowed down in the last few days without any increase in the test positivity rates. However, I think that would be a long bow for me to say that it was what we announced last Thursday, so I don't think we can draw any conclusions from that. What I would say is that if we want that to actually be a real peak and case numbers to drop again, that if people do the actions that we talked about last Thursday and reiterated today, that will make a difference, I'm confident.
Talking more broadly about where New Zealand is at kind of in the pandemic, 10 is kind of crisis mode, 1 is like we don't have to worry. How would you describe where we're kind of at?
Okay, well, I can probably bench this against how well I'm sleeping, benchmark this against how well I'm sleeping. Look, I think what we all need to be cognizant of every day is there is still a global pandemic. And it's not just what's happening in New Zealand, it's what's happening globally. And the context globally is that we're still seeing the development of these ever more transmissible variants or subvariants, and that there could become a time where one of those is actually more severe than perhaps Omicron is. And we need to absolutely keep our wits about us. Likewise, we're hearing every day about the pressures that are on our healthcare system, and COVID-19 is a significant contributor to that. Over nearly 800 people in hospital with COVID-19, and a good proportion of those would not be in hospital if they didn't have that infection. So I don't want to necessarily put a number on it, but we're nowhere near 1, that's for sure. And we need to keep doing what we have been doing. We're not out of the woods yet on this.
For you personally, how does it feel to be staring down the barrel of ending the job and sort of walking out this building for the last time?
Well, I'm going to talk a little bit more about that, I think, in some interviews next week. But a key thing for me is I feel absolutely confident that the public health response and all the government response is in really good hands. We've got Andrew here, very experienced public health doctor. Dr. Diana Safati, who's coming in as acting Director General, is a public health doctor, and there are really well functioning teams across this organisation and Health New Zealand, Te Whatu Ora, that will be leading the response from here. So I'm confident that things are in really good hands.
What's next for you?
A good break.
And the gathering limits today, does that mean no karaoke tonight?
We've cancelled karaoke. There was no karaoke tonight. It's not something you generally do when there are senior public service people and politicians around. We were going to have a good fun evening next week. We'll do that later in the year, I hope, if the staff here still want to come, when things are not in the situation. From my perspective, this is not the time for us to be doing those things. We know that they're the sorts of events that people are likely to spread COVID, usually unwillingly, because they may be asymptomatic.
And would you be suggesting that other organisers do the same? They postpone big events for past this next 6 weeks, please?
Well, just to go back to my earlier comments, there are measures that can be put in place to make events safer. So I think there are things that organisers can do and things that attendees can do, and the most important for attendees is not to go if you're unwell or if you should be isolating as a household contact. But yes, if there are things that can be deferred, this might be a good period when to just defer those to later in the year.
Have you had any initial figures on the uptake of the free RATS system, and also do you have any more information on, in terms of an update on the overall pressures on hospitals from everything?
So on the first question, I don't have any figures, but we can provide an update on the number of tests distributed since last Thursday when the announcement was made and how that compares with earlier distribution. So we can provide those figures afterwards. The pressure on our hospitals and general practices and community providers is similar to what it has been. We have seen drop-off in influenza, but there's still high rates of people presenting at emergency departments, and so it's a daily and sometimes 2 or 3 times a day exercise in each district to look at how they can move staff to make sure that people who are acutely unwell can get the care they need. Please.
Have you had any conversations with your counterparts in the Pacific? Obviously there was the Pacific Islands Forum last week, and it seems as if there has been a bit of spread go on as a result of that gathering. Have you heard whether that has had any impact on nations as leaders and things have headed back to their home countries?
We haven't had any reports back yet, but again, that's something we can look at. We haven't had any requests for assistance. We have been providing some assistance into Niue since they had that first flight that went in late June that ended up having some cases on it, and so we've had a team over there supporting them in their response, and that's been a daily interaction and support from here as well, but nothing subsequent to the Pacific Islands Forum.
How are things going in terms of Niue? Are they improving or?
Yes, I just read the latest report yesterday. They've had some cases there. They're all related to the border, so people having recently arrived or immediate contacts, and the procedures they've put in place around isolation and testing are containing that so far. Of course, Niue has extremely high rates of vaccination, which is a really good starting point for them.
Can I just circle back to the booster shot? I know you said you have the figures separately, but just generally, are you satisfied with what the uptake has been recently? Well,
there are the 2 boosters. The first booster, which has been rolled out for a while, we've hit around early 72-73% coverage. Very similar to what other countries are finding. There is a drop-off between the initial course and that first booster. One of the good things is that since the second booster was made available, we've seen an increase in uptake of that first booster. And so far, pretty good uptake of the second booster. I would like to see that going up, because at the moment, about somewhere between 30 and 35% of people who are already eligible for that second booster have had it. Between now and the end of July, there's over 1 million people that become eligible, and we've got the capacity in the system, we've got the vaccine, and this is something people can do. And there is evidence emerging, in fact, 2 studies in major medical journals published just in the last few days that have shown the benefits of that second booster, not just in reducing the risk of severe infection and death, but actually reducing the risk of being infected in the first place. It's a smaller impact than it was for the earlier variants, but it is there. Andrew's very keen for a question if you've got any for him.
And this is about monkeypox, so I don't know who's a monkeypox person.
Try me first, and if I can't answer, I'll hand over.
Where are we at with a potential vaccination campaign for monkeypox, particularly for at-risk populations?
Yeah, we are in the process, and Pharmac's working actively with the single vaccine manufacturer to get some of the vaccine that is used, remembering that it's a smallpox vaccine that can be used. It's one of the 3rd generation ones. So why don't we aim to have an update either later this week or next on just how that discussion is going. I'm just not au fait with where that is, but it's productive. Yeah. And so far, just to reiterate, just the 2 cases of monkeypox we've reported in New Zealand, no further cases, both people who had travelled overseas recently, and no evidence of any community transmission at this point. Any final questions?
Well, since there's no one, are you keen to do a preventative sort of vaccination campaign, or is it sort of not going to be like that? Or?
It's one of the tools in the toolbox. At the moment, we're not in a position where we would need to use it, but of course we want to have access to it if it is going to be something that could be important if we did have the potential for community spread. I know a number of other countries are doing ring vaccination efforts.
Could you just shed a bit of light on the testing a sort of sample of Kiwis to go and understand the sort of true scale of the outbreak? Just a bit more detail kind of on that.
On the prevalence survey?
Yeah.
I've probably given you all the detail I can provide off the top of my head, but we can send some further follow-up info. In fact, I think there were some media inquiries earlier today, and we've sent some information around to whoever inquired, and we're happy to send that more widely.
Do you still think it's about twice what the testing is?
Yes, if we look at the number of tests we are getting, our surveillance testing, our wastewater testing, and the positivity rates, it's about twice the number, and it's just hard to know what the breakdown is of those tests. Some of those are people who might be testing and isolating but just not recording the results. I should say though, New Zealand continues to have one of the highest testing rates in the world, and it gives us a very good picture of the burden of disease, and it really informs our response. So the fact that today over 10,000 people have been reported who yesterday did a test, uploaded the result, and are now isolating is just fantastic to be this far into the Omicron outbreak and that happening. Encourage people to keep doing that. It's absolutely fundamental to us managing the outbreak.
Just back on the booster, sorry if this has been asked, but given there is supply and the uptake hasn't been as high as you might want it to be, is there any consideration being given to opening it up to people outside of the current grouping? Yeah,
so at the moment we've got one of the widest eligible set of eligibility criteria in the world. I know that Australia, a little bit after us, they opened up initially to I think over 65s. They've now dropped that to down to 50 and above recommended. 30 to 49 is it's if people want to have it, they can. So that's the group, and we have been asked to have a look at that. And so we are looking at that at the moment, and also the interval. At the moment we're saying 6 months since the second booster, so we're just going to have a look and see. But as I say, over 1 million people become eligible in these next few weeks. The more important thing, because they are the people who are at higher risk, is that those people get vaccinated as soon as possible after they become eligible.
And do you anticipate that you might make a decision around that 30 to 49-year-old age group?
Well, we will give advice. The government will make the decision, but it may well be within the next couple of weeks if that's something to do. So we've got capacity in the system, we've got the vaccine, and as I say, at the moment we've got quite wide access criteria, which includes any health or disability professional down to age 30, and it's just, and the most important thing is that we focus on, first of all, vaccinating those priority populations.
And what would you say to those people that are eligible at the moment? I know a few in my family, and kind of dragging their heels a bit on it, saying, we don't think the vaccine's as effective as it was, we can't be bothered getting another jab. What would your message be to them?
Well, first of all, in terms of the vaccine effectiveness, the studies I talked about, two really quite big studies, one in I think Canada and the other in Sweden, and we're happy to circulate the references to those, show a really important improvement in protection against hospitalisation and death, and as I say, even transmission. And this is particularly, these were in older people. So for anyone who's over my age, 57 and older, then definitely worth getting the vaccine, and consider it even under that age. I would strongly recommend anyone. I will be. I'm not eligible yet because it's still within the 3-month window of when I had COVID. I strongly recommend anyone get that 4th vaccine. There is really substantial evidence about the benefit of that now. We've got people ready and waiting. We've got appointments. So go to it. It will help protect you during winter.
And you've also got over 30s that want to do it. So where's the urgency in allowing them?
Because the recommendations that I've made, and also just actually, just to reflect on an earlier comment, it is a Director General decision now to allow these vaccines to be given to certain age groups. At the moment, the evidence and the advice I have had from our technical advisory group is aligned with the categories we've got. I'll wait till I've had that updated advice, but it's very clear that the benefit is there for the groups that are currently eligible.
So you wouldn't need Cabinet approval, you would just sign that off if you thought that that's the right thing to do?
That's correct. It would be myself or either the incoming Acting Director General would be able to do that, but it's not something that's done lightly, because effectively it's being prescribed and done off-label, and so it's something one does on the basis of really good advice.
You're a bit of a rugby fan and like the COVID response, rugby brings the country together. Do you have a view on the coaching position?
I don't have a view, but thank you for the question because it allows me to explain my hoarse throat. It's not due to any current or recent respiratory infection, but I was yelling instructions loudly at the All Blacks on Saturday night, and unfortunately they didn't seem to take any notice of what my suggestions were. So quite clearly, even though I'm finishing at the end of next week, I will not be in the running for the All Black coaching job.
Were you at the game or yelling at your TV?
I was at the game, and I have to say it was a great atmosphere there, and it was a great game to watch, and really enjoyed it. Thanks very much, everybody. Have a good day.
You too.